Wonderful, thank you. And good afternoon, everyone. It's wonderful to be here to talk to you today and talk about a bit about how we move from recognition of all the harms to repair. And it's been, I know, a long road for many of us in that discussion. I am Melissa Jones from BARHI. I'm the executive director here. Next slide, please. BARHI is the coalition of the Bay Area's governmental public health departments. We were founded when 4 sitting public health directors took a deep look at the data around life expectancy by race, class, and geography, and saw decade-long differences between particularly African American communities, particularly low-income African American communities, and the richer, whiter communities within zip codes. The group really looked and thought very deeply about what could bring about a change to that decade-long difference, and developed a series of strategies that have been in place to move this forward. Next slide, please. And those strategies have really shaped much of health equity, both in the Bay Area and in the country. And so here I have the differences in the United States, in California, in the Bay Area, and in the other regions of our country of life expectancy by race. But since the last 2 folks also talked about that, I'm going to go to the next slide and talk a bit about the BARHI framework. The BARHI framework is based on a lot of the same data and information that's been adopted by the World Health Organization to explain differences in life expectancy. And it's really based in this idea that the living conditions, institutional inequities, and social inequities that shape our experience have a great deal to do with the mortality differences that we see. Indeed, the World Health Organization says 80% of the cause of the differences that we see. And this is a framework that's been adopted and widely used by a number of influential organizations in health, and is really accepted as a standard of understanding what is causing these large differences in life expectancy that we see. The inaugural framework for the California Department of Public Health's Office of Health Equity, guiding their first strategic plan and grant making. It's used in public health accreditation nationally across the country and through the National Association of City and County Health Officers for their planning around the MAP accreditation process. And it's used by the American Medical Association in their health equity unit focused on their most recent health equity plan. Slide, please. And it really holds, next slide, please. Yes, and it really holds to that focus on the 80%. Slide, please. And we often talk about back one, thank you. We often talk about the social determinants of health and their incredible direct line impact to health, right? Disparities in education, in engagement with the criminal justice system. But I want to talk about a much more personal piece of the health equity pieces of the work, how it travels in a family. And so there is now very clear research on the impact of racism on health. And in particular, on the way that cortisol has located itself in our bodies in a response to acts of racism and in response to racism. So cortisol, you probably know, is a stress hormone, can be activated and released over an extended period of time for many reasons. It creates this sort of pressure, this sort of swirl in the body. And studies have found that African American adults have sort of flatter cortisol slopes from wake up to bedtime than their average white counterparts. These flattened slopes are linked to poor emotional and physical health and really contribute to issues of cardiovascular disease. And that's now very well established. There's been a meta-analysis of 80 studies across all ages, ranging from children to adults. So it's a very big and clear way that the racism that undergirds our full history from slavery through to the present really creates personally in our body this very heavy burden. Next slide, please. And these heavy burdens, When they do bring us to the doctor's office, bring us to a doctor's office not well prepared to meet our needs. And so here you see some data similar to data that somebody spoke about a bit earlier in the conversation that's focused on white medical learners' enduring beliefs about biological differences between Blacks and whites. This is data from 2016, so it's very recent data. And it shows by percentage and by medical year, beliefs around that we feel less pain, right? That we have stronger immune systems, a range of things that can lower a doctor's attention, both to our ailments and to what needs to happen next. And next slide, please. And we know this anecdotally too. We know that almost half of African Americans in California report that they have experienced unfair treatment due to race. We know that NAM has found that racial and ethnic minorities receive lower quality health care than whites, even when insurance holds even and similar insurance status, income, age, and severity of condition. And we know that in surveys of hospitals across the country that Black patients with heart disease receive older, cheaper, and more conservative treatments than their white counterparts. Next slide, please. And this shows up in our maternal health outcomes as well, as was mentioned earlier. So I'll just mention one. One thing that we know is, for example, for Black babies in the Bay Area, similar to other parts of California, we're two times more likely to be born too soon, too small, or to die before the first year of birth. Next slide. We also know that there are things that change that outcome. And one of the most comprehensive studies that's been done on that fact across 1.8 million hospital records from 1992 to 2015 show that infant mortality rate is cut in half. And it's cut in half when a Black doctor is the primary charge on these cases. And that brings me to the piece of the conversation around health that we often don't have, which is that the injustices in other parts of our system land in our healthcare system. And so the injustices in our public education system that result in a fewer number of Black doctors result in an unmet need for Black doctors that really could be part of a cycle of changing the birth outcomes that we see. And that's just one example of how an injustice in one part of the sector will come to show up in health. And it's a very important example for our life expectancy. Slide, please. And these examples of both the incredible injustice in differences in life expectancy, the direct relationship of that to the racism that we've experienced across history and into the present day, and the fact that we do know there are solutions that are based in community provision of care, has really given rise to a movement nationally and here in California focused on racism itself as a public health issue. And so on April 8th, 2021, Dr. Rochelle Walensky, CDC director, issued a statement that racism is a serious public health threat and recognized the important role of the CDC in addressing the impact of racism on public health. In the time subsequent and since then, over 200 jurisdictions and over 30 states have now declared racism as a public health issue. Next slide, please. Thank you. Next slide. It's 2 taps, I think, for everything to come through. Thank you. And so as we think about addressing racism as a root cause and think about ending our differences in life expectancy, I think that there's great lessons from housing and issues of affirmatively furthering fair housing. I think what housing has told us over time is that laws help, that enforcement works better, right? That we need the combination of the two, and that even with the combination of the two, redressing the harm is the only thing that would really close the gap. We've seen that in home ownership, in purchasing, in lending disparities, and in apartment rentals. And so it's really thrilling to be able to talk to you all because I know you're thinking really about redressing the harm. that has been a burden on Black Californians for such a long time. Next slide, please. And so I end again with the differences on life expectancy, how they've pulled through the historical moments into a piece of harm. Next slide, please. And want to talk a little bit about the bright spots, the things that might indicate for us just what the potential of reparations is for our health. And so policies that reduce poverty and raise wages of low-income people can be expected to significantly improve overall health and reduce health inequities. There's been a lot of research on that by us and by others. And that negative economic shocks cause mental illness, and anti-poverty programs such as cash transfers really bump up and improve mental health. And then an assessment from the Stockton demonstration on basic income. After 1 year of cash payments, there was a significant reduction in anxiety and depression compared to levels seen in the control group. So as much as the $500 that they provided was as effective as other forms of medication. Now, I'm not suggesting that that be the number. I think the redress of the harms cumulative over the structural impacts on from housing to education to health are much larger. But the idea that cash in and of itself has this protective factor for health, and it is one of in income and wage is one of the longest harms sort of generationally passed from slavery is really, I think, an important piece. Next slide, please. And so I just share 3 bright spots. Similar to the fact that we know Black doctors are having such a dramatic impact in lowering infant mortality, I also want to share several other programs that are coming from community that seem to be having really promising potential for reducing the disparities that we've seen in health, all of which are tied to conversations about repair and, in particular, cash reparation. One is the Magnolia Mothers Trust out of Jackson, Mississippi, which has been providing guaranteed income programs for mothers in Jackson with similar outcomes to what we've seen in Stockton in terms of relief of stress, better improved health outcomes, a longer opportunity to spend time finding the right job and sort of getting a job that pays more by being able to hold out a little bit longer and go to that next couple of rounds of interviews. The kinds of things that give people flexibility, the kinds of flexibility it's hard to have when we don't have the generational wealth of other communities. The second is the Abundant Birth Project, which provides unconditional monthly income supplements of $1,000 to approximately 150 Black and Pacific Islander mothers in San Francisco. This is a project that's just starting. It's something that we have our eye on. It's got a very robust evaluation that goes with it to help us see the change in outcomes that we can see, these very important life and death outcomes. And then the last is Barhigh's Black Hat Initiative, where we've worked with 40 Black-led developers and housing finance people from across the Bay Area to really take a look at the massive pattern of Black displacement that we've experienced in the Bay, from San Francisco to Berkeley, now here in Oakland, that has really shaped and changed the Bay Area. And we've come up with a plan that really focuses on an end to that mass displacement through Black-led development and Black planning for the Black Bay Area in terms of community and housing to create communities of health, prosperity, and justice. And so each of these are the kinds of investments we think could be really powerful health promoting activities that we really believe there's been now a body of research to really support their potential if scaled. Next slide, please. And thank you. With that, I'll end. And I just want to thank you so much for your time today and look forward to answering any questions that you may have.